el instituto, en el Hospital Mercy de San Luis, tiene un departamento de FertilityCare, donde ella trabaja como co-directora y trabaja con Diane Daly, que es otra de las cofundadoras de este proyecto, junto con el doctor Thomas Hilgers y su señora Susan Hilgers. Ellos cuatro, desde hace 30 años, trabajan juntos en esta área, y yo he tenido el gusto de poder compartir con ellos el comienzo de mi entrenamiento como médico de consulta para naprotecnología. La razón de la visita de Ann a la Argentina es porque la señora Beatriz Donnelly de Richards y su hija Candela Richards son las primeras practitioners, es decir, son las dos primeras personas entrenadas en FertilityCare como para introducir FertilityCare, Creighton Model y a través nuestro Naprotechnology en nuestro país. Ellos nos explican siempre que no han tenido una agenda, que esto ha ido creciendo con toda naturalidad, pero en este momento en todo el mundo hay gente que está trabajando con el modelo Creighton y con la naprotecnología. Nosotros tenemos como proyecto para el año que viene, si Dios quiere, una vez que estemos certificadas, las dos practitioners y yo, instalar en el Hospital Austral un centro de atención a la fertilidad según este modelo. Así que en este momento estamos en una situación de privilegio por tener a Ann con nosotros, y entonces ella nos explicará perfectamente qué es FertilityCare, qué es el modelo Creighton y qué es la naprotecnología. Muchas gracias. Thank you very much, Ann, to be here with us.
Hola. Good afternoon, everyone. I am really honored to be here. This is my first time in Argentina, and this is quite an opportunity for me to be here talking about the Creighton Model Fertility Care Services. What I have prepared for you today is to give you, some background about how this got started, the Creighton Model Fertility Care System. The second is to talk about what is the Creighton Model Fertility Care System. I'm going to briefly touch on the education of teachers, but more importantly, talk about the education of clients. And then I will end with discussing and presenting some information about naprotechnology. So it all began back in 1976. And the reason it began is because some years before that, Dr. Hilgers was inspired by the encyclical Humanae Vitae. And he was inspired by the encyclical and the call to men of science. And ever since that time, he has been devoted to promoting the Creighton model fertility care system and all the things that that means, and macro-technology. It was a process. It was a lot of patience. It was a lot of passion and prayer that brought this into being. As was presented, there were 4 of us that worked together. It was Dr. Hilgers, his wife Sue, Diane Daly, and myself that have worked together since 1976. So for 38 years we have worked together. And when we began working, the things that we wanted to be able to do was to develop a standardized way of describing the mucus observations. Because in order to do research, there had to be a standard way of making observations. So from the very first day, that was one of the goals. The other goal was to also be able to reproduce the information so that there could be more people that could learn about it and they could learn about the method. So we needed to have more teachers, more physicians that could learn. So the education was important as well as the standardization. So if you will, standardization was critical. The method is a prospective method. So it doesn't really matter what happened yesterday, but it happens what happens today, and it's reproducible. The way we did this is we had weeks, the 4 of us would meet, and we would brainstorm about what we did the previous week, the people that we had taught. So we were trying to figure out how to teach people this system, what to teach them, how to problem solve, what to document, and how do we manage cases. So truly, once a week we met, the 4 of us, and brainstormed to try to figure out what we were doing. What we found is that our clients that came were all using different fertility languages. One woman would describe the mucus one way, another woman another way. But when you listen to them, they were really saying the same thing. They just were using different words. We did this through something called individual follow-up sessions. We met with people individually in an office, and it might be one teacher and one woman, or it might be one teacher and a couple, but they were always individual. And we always scheduled appointments, so we always knew who was going to come. We spent hours talking to people about what the mucus looked like. We'd ask them, what did it look like? We would listen. They would talk, we would listen. Now, what happened is the women would check for the mucus. And when Dr. Hilgers was in the office, women would come in, they would have an appointment with him, and before he came into the room, they would check for the mucus. Then there was followed by an examination, and what he did something of ferning. He would take a sample of the cervical mucus for ferning. He would also take a sample of the cervical mucus for Davignon channels. And the mucus was evaluated because we would call the women later to find out where they were in their cycle. Now, about after 250 of these examinations, and I was present at most of them, we called the photographer to come up and take pictures of what they were seeing, because we were seeing the same things. God is very clever. There's only so many things that women see. It's not endless. But if you listen to people, they were all using different words. But when you really heard what they were seeing, there were very few things that women saw. So what happened is the Creighton model became an objective, universal language. We developed something called the vaginal discharge recording system. And what's interesting about the recording system, it doesn't matter where you are in the world, it's the same. So if you are in Argentina, if you're in Hungary, if you're in the United States, if you are in France, everybody uses the same recording system. And that's wonderful because we can all communicate about what's ever on a chart. From the very beginning, the method was always taught as a method not only about avoiding a pregnancy, but also about achieving. It was both avoiding pregnancy and achieving a pregnancy. And that was very, very important in the instruction and in our work. We developed a standardized way of teaching. So there were certain things that we would teach people at one teaching session and the next teaching session and the next teaching that I'll explain in a little bit. And we use something called a case management approach. So we look at the whole situation for the couple and not just one problem or two problems, but their whole situation. So it was objective understanding of fertility in the menstrual cycle that each woman can monitor their reproductive health. It was so amazing because women, by making these observations, could tell what their body was telling them. We found that there were no side effects to using this Creighton model fertility care system. It was complete family planning to either avoid or to achieve. And somebody could use this before as a young girl and use it through a reproductive lifetime, no matter what kind of cycle she had. Somebody could use it to achieve pregnancy, avoid. They could use it if they had irregular cycles. They could use it during breastfeeding, totally, or in the process of weaning the baby from the breast. So there wasn't one time in a reproductive life, not one moment, that somebody could not use this information. Another advantage, it was not just the woman's method, it was really the couple's method. Two people working together on one system. So from the very beginning, we always taught this to a couple. Sometimes the men were not able to be there. Thanks, now. Sometimes the men were not able to be there, but we still talked as they were because we wanted them to know that this was their method. Now, I have a few slides that I need to present to you. This is one of the slides that we use in our introductory session. So when we teach people the method, the Creighton model system works by something called the introductory session. It's a PowerPoint presentation that generally takes 1 hour, 60 minutes to present. Then, if people say, I want to learn the Creighton model system, they would sign up for individual follow-up sessions. Now, one of the unique features of this is we never, ever give out materials to people unless they have a follow-up. Because the method, it depends on how well it's taught, how well it's learned. The better we can teach it, and I'm a teacher, the better somebody could use it. So we never just pass out materials. They have to have scheduled follow-up. So this is, and the next few slides show you some of the slides that we have in our introductory session. Obviously, these are the two ovarian hormones. And estrogen. Thank you. This is, the estrogen is diagrammed in red, the progesterone in green. This dotted vertical line, of course, indicates the day of ovulation. So we teach people about their estrogen and progesterone hormones and teach them that these two hormones really drive the changes in the method, in a natural method. Whether they're learning the Creighton model fertility care system, whether they're learning the billings, whether they're using symptothermal, it all depends on these two hormones that causes the changes in the woman's body. This, for us, is a very important part of the uterus. This, of course, is the cervix, and the cervix is the lower part of the woman's uterus. This is the endocervical canal, and off the endocervical canal, there are about 100 cervical crypts. And these cervical crypts are lined with specialized cells. Some of the cells secrete mucus, and some are called ciliated cells that move the mucus out of the cervical crypt into the endocervical canal. Now the ratio is there are 20 secretory cells to every 1 ciliated cells. And we owe the information about the cervical mucus to a wonderful man by the name of Dr. Eric Oderblad, who has done more work on the cervix than anyone in the world. Now, there are 2 types of mucus generally that are produced. One is called estrogen, or E, type E mucus. This mucus, when it has a high water content, low protein, low mineral salts, and then when it's looked at, it looks like parallel channels are swimming lanes for the sperm. The sperm can quickly go through this mucus. The progesterone produces a different type of mucus, and this mucus has a lower water content, more protein, more mineral salts, and although it's produced, it stays in the cervix, where type E, estrogen related, will flow from the cervix through the vagina, and the woman will see it externally. So when we talk about the Creighton model fertility care system, we are talking about external observations of mucus at the opening of the vagina, which is what the Billings method also taught, the external observation of the mucus. So the mucus will flow from the cervix through the vagina, the woman will see it externally, and that's what women will describe. The cervix is a biological valve. Sometimes it's open and sometimes it's closed. But the real beauty of all this is that women with a 99.9 degree accuracy can tell whether this biological valve is open or whether it's closed. This is the wheel, and if I were going to be teaching everybody today the method, I would teach you in great detail based on what you see here. This is what happens during the course of a menstrual cycle. The menstrual period is the beginning of the cycle, and that can last a variety of days, maybe 3 to 7 days. Usually starts as a heavy flow and progresses to light. Following that, there is a period of dry days where a woman does not see mucus. Then the mucus begins. The mucus generally begins as a sticky or tacky mucus and progresses over a period of days to what we call peak type mucus, which can be clear, stretchy, or lubricative, any of those characteristics. Then something magical happens. All of a sudden one day, the mucus changes. It totally goes away. It's no longer clear or stretchy or lubricative, and it goes back to sticky or cloudy, or goes completely where there's no mucus. Now, and then it continues on through where there's no mucus to the beginning of the next cycle. The last day, and this is important, the last day of mucus that is either clear or stretchy or lubricative is what we call the peak day. So in the Creighton model fertility care system, we are not teaching people to find the day of ovulation. We are having them define their fertile and infertile days. So we don't teach people, this is the day of ovulation, but we teach them the fertile and infertile days. And here's another interesting point. When a woman starts her period, from that day to the last day of mucus, clear, stretchy, lubricative, is variable, can be any number of days, could be 9, 14, 50, anything. But after a woman has her peak day, she should have her next period in an average of 12 days. Now we're going to come back to that when I start talking about nephro-technology. Now, when you take the wheel, we call it the wheel, and put it out, it looks like this. So let me show you. This is an example of charting, and I have several to show you this afternoon. The chart, we use a system, it's a paper chart, and on kind of heavy paper. When women in a couple's chart, they have a chart like this because it has 35 days. Most women have cycles somewhere between 25 and 35 days. There's room for 6 cycles of charting on one of these charts. There's a place for a description and a place for the stamp. The description says this is what the woman is seeing. The stamp says this is what it is for us as a couple. This is our fertile day. This is our infertile day. So it's a description and a stamp, and it's the guide to the woman, to the man, to the couple about their fertility. This is the similar chart, but what you see here are the hormone levels. The estrogen is diagrammed in a black bar, the progesterone in gray. And what you'll see, how the estrogen levels increase as the mucus changes during the course. Now, when we read this mucus is generally sticky, cloudy, tacky, cloudy, stretchy, clear, lubricative, stretchy, clear, lubricative, stretchy, clear, lubricative. And as the days progress and the mucus changes, the estrogen levels are increasing. There is a secondary rise of the estrogen, but it's really all overshadowed by the presence of progesterone. This is our recording system. And as I mentioned, the recording system, the way the mucus is described, is the same wherever you are in the world, Taiwan, anywhere. So it's the same. And we did that because people can communicate worldwide about what they're seeing. And I guess I really want to make the point. There are, would you say there's millions of women in the world, but they see the same thing. They don't see endless amounts of mucus discharges. There are just so many things. And I think that's pretty amazing that was the way that God created us. It just took a long time to figure out these are the possibilities. So in order to change the way women recorded, because when you look at a chart in Argentina, a Spanish chart in Argentina, or if you're looking at a French one in Paris, the words to describe this damp without lubrication will be in the individual language, but the way it's recorded is with a 2. So this 0, 2, 2W, 6, 8, 10, those numbers are the same and they don't change. It's kind of good too, because what people tell me when I'm teaching them is, this is really great when we're using this recording system. And so people can communicate very easily with their iPhones and sending messages back and forth very quickly. So the couples tell me that it really facilitates their communication. What I wanted to show you, and I'm going to go back just a little bit. When Dr. Hilgers started this, he, with another doctor at our St. Louis University, received a grant from our National Institute of Health. It was a good-sized grant 40 years ago. It was $100,000. And the purpose of this study, for this grant, was to correlate when ovulation occurred around the peak day. The women that were participated, there were 24 women, and they contributed 65 cycles. This was really the basis for where we are today with the Creighton model fertility care system. Now, originally, it had been done, this kind of research had been done in Australia, it had been done in Canada, also in England. But we also were able to do this. We did the largest study that's ever been done. And when we did this, we found out that when women identify the peak day, we can tell them when ovulation is occurring. And I'm going to go back, excuse me, to something. So, when we see a chart like this, when the woman identifies her peak day, the peak day is the last day of use, clear, stretchy, or lubricative. That's a marker. It's not the same as ovulation. It's a landmark or a marker. And this is what we know to be true. When a woman identifies her peak day, she will ovulate 1, 2, or 3 days before the peak day. Peak day, 1, 2, 3 days afterwards. And 95% of the time, ovulation will occur 2 days before peak, or 2 days afterwards. So, as I said earlier, we don't teach women when this is the day you ovulate, but we can tell them precisely when they ovulate. Here's another little tidbit, or little piece. It's interesting because within the same woman, she might ovulate 2 days before peak one cycle, 2 days after the next. She won't always ovulate the same time around peak. It'll change, but it'll be within that window of time. This, what I wanted to show you here, is some effectiveness numbers. People will say, well, how effective is the method to avoid? This was a composite study of, there were 5 different centers that were involved in this. And this will show you the method and use effectiveness to avoid pregnancy. This was done over a period of time from 1980 to 1995, excuse me, to 1994. The method effectiveness was 99.5. The use effectiveness was 96.8. It's pretty good. It's not 100%. We can't teach. We don't know how to teach. There is no way to teach somebody 100% to avoid a pregnancy. But no method is. But it can be very effective if somebody wants to avoid pregnancy. And here's the important thing. When we talk about use effectiveness of any method, because every method has not only a method of avoiding, they have a method effectiveness, they also have a use effectiveness. The method effectiveness should be how perfect it should be. The use effectiveness is how effective it is on a day-to-day basis. So with the Creighton model system, it depends how well it's taught, how well it's learned. The better taught, the better learned, the more effective the method can be. So if you will, The standardized charting was a window, and it opened a door. So women, by making external observations of mucus, can tell what's going on at the cervix, and that will tell the woman, the couple, is this a time of fertility or infertility for us? Another point would be to tell you, if a couple's experience with a natural method was not a positive one due to inadequate teaching, a couple may never return to a natural system. So we were always dedicated to make sure people were well taught, they learned the method well, so that they could feel that they could use a natural system for a reproductive lifetime. And that was a real, very, very important concept for us. So the Creighton model versus the Creighton model system is not viewed just as a diagnostic tool that I'm going to talk about, ignoring the true family planning component to avoid and to achieve. But it also focused on the couple's sexuality and fostering communication. So we were also concerned about building couples' relationships, building their marriages, helping them improve communication. Now, quickly, I want to tell you, when somebody learns to be a teacher or becomes a medical consultant in our world, they experience what's called a core curriculum, which is a certain standard set of classes that they attend, and it's very specific what is to be taught and what needs to be learned. It's professional core curriculum meets professional needs. It's fully integrated, and it's not only lectures, but it's also clinical experience. And the people that provide this are people that are trained educators, like I am a trained educator, so I can teach people how to be teachers. And it's always based on sound ethical formation. We do a 13-month certificate course. There's 2 educational phases. There's a total immersion of 8 days and 7 days, and these are 6 months apart. We also do something called an on-site visit. So we go out and watch the people, the practitioners, the new teachers, what they're teaching, how they do everything, how they do a follow-up, how they do an introductory session, how they are managing the cases. And the on-site visit is what brings me to Buenos Aires, because I'm doing 2 on-site visits. And so this is it's the second part of their program. And so in order for Candela and Beatriz to finish, they have to have me watch them and grade their activities. And eventually, and actually in February, Beatriz and Candela will be taking a final exam, an international exam. Quickly, we have programs. In 1978, there was 1 educational programs. Now we have 19 worldwide. Quickly, in Omaha, there have been educated, and notice I say not trained, but educated, 1,571 practitioners. There are 65 people like myself. We also have supervisors, and we have 649 medical consultants. So the standardization of the mucus observation led to the standardization of client teaching system materials. And the standardized chart showed something called biomarkers, what I'll be talking about. I just want to show you quickly, these are some of our materials. It's the book that we use. This is our anatomy and physiology book. This is our book 1, and we have a book 2. This is the teacher's manual. We also have something called the picture dictionary, and I'm going to show you a few pages for this. Now, the picture dictionary was developed through an orderly research assessment of the vulvar observations. Women made observations, they observed the mucus, and after about actually 150, 250 150 women, over 440 observations, there was born what we call the picture dictionary. The observations are universal, and it hasn't changed since 1977. These are 2 pages out of our picture dictionary. The picture dictionary will show women the different types of discharges they could see. They could see something like this, which is a vaginal discharge, pasty. They could see variations of cervical mucus. This is some of the peak type mucus that women can see. So when we're teaching people, we can have them and compare what they see to these mucus observations, so that will help them focus on what are the possibilities that they can see. Again, it's standardized observations. Dr. Hilgers wrote a textbook in 2004, and it's called The Medical Surgical Practice of Neprotechnology. And if I had this book today, I'd be holding a 12-pound book. So it's very important. He's in the process of updating this and revising it. We have people that are medical consultants that help us as practitioners, and I'm a practitioner like Candela, like Beatriz, and we teach people the method. We teach them the Creighton model fertility care system. We do not practice medicine. We do not practice, I'm going to introduce a word to you called neprotechnology. And explain that. When we teach people, we use something called a follow-up form. This is a 30-page document, and if you will, it's our medical, it's not our medical record, but it's our record of everything we're teaching. It's very precise, very detailed, and if you would talk to Candela or Beatriz, they would tell you that it's a lot of individual information. Every person that we teach has access to all the information, and yet, it allows us to modify the instructions. So if somebody's premenopausal, different information to give them than if they're coming off birth control pills or breastfeeding. So it still allows a lot of think of nanotechnology, it involves medical, perinatal, and surgical applications. Okay, so let's take a look at some of the things that nanotechnology will find or can come up against. That nanotechnology evaluates and treats things as infertility. And what's interesting is that the number of couples coming with infertility is increasing worldwide, and in our city in St. Louis, Missouri, we used to maybe have 10 to 15% of people coming to us with infertility. Nowadays, I would tell you it's about 30% of couples that come are coming struggling with infertility. So that's very different. I think in Europe, and also what I'm learning in South America, there's more and more people, a bigger percentage of people are coming struggling with infertility. We have people that have are coming to us with recurrent miscarriage, or recurrent ovarian cysts, abnormal bleeding. Maybe it's because they got tail end brown bleeding that goes on for days at the end of the cycle. Maybe it's intermenstrual bleeding, maybe it's premenstrual spotting. We're working with many people with premenstrual syndrome. Prematurity is part of nanotechnology and treatment for prematurity. Premature rupture of membranes, again, that's part of nanotechnology. Progesterone deficiency in pregnancy can be treated with nanotechnology. Many people are struggling with endometriosis, and that's something that can be treated. And endometriosis has caused in my experience, has caused major problems for women. And it's interesting because some people don't even know they have endometriosis until they've been struggling with infertility, and they have surgery, a diagnostic laparoscopy, and the doctor finds multiple spots of extensive endometriosis. Women can have dysmenorrhea, pelvic pain, polycystic ovaries, extensive adhesions, and other hormonal issues. So these are many things that a woman could experience. And here's the interesting thing, is by doing the charting, many of these things, not necessarily prematurity or the premature rupture of membrane, are progesterone deficiency in pregnancy, but everything else you can see on a chart, not direct diagnose it. You can't make a direct diagnosis of these things from the chart, but it's a precursor. It's a way where if it's on the chart and it's gone to one of the medical consultants, they can recognize this and it can be treated. This is one of our charts that we show, and I got a couple to demonstrate. The first one, is somebody with a very limited amount of mucus. Now, the typical mucus cycle is 6 days long, not just one. And this could be somebody very easily that's struggling with infertility, where they have a limited amount of mucus. And the second example is somebody with a very sharp post-peak phase. As I mentioned earlier, a normal post-peak phase, the time after the peak to the next period, is an average of 12 days, not just 5, like this. This is somebody that's really at risk for miscarriage if they try to achieve a pregnancy. There's not enough hormonal support to maintain the pregnancy. I recently had one of my clients that came, and she had had a history of 5 miscarriages. She started seeing one of our medical consultants, and now they have a little boy with treatment with surgery. She had endometriosis, she needed progesterone support, and they have a little son now after 5 miscarriages. Oh, in 2 years, all these miscarriages. Sometimes women will see this brown spotting or very light spotting at the end of their period. That can be due to low progesterone. And something like this is abnormal bleeding. So what I'm showing you here on this one chart are biomarkers. They are things that appear on the chart that will present as potential problems that can be evaluated and treated. So people don't have to struggle with infertility, miscarriage, low progesterone, or abnormal bleeding. And let's see, I put this in because I wanted to give you another example. This would be somebody struggling with infertility. Once again, it's a limited amount of mucus. It's not 6 days, it's only 1. This is also limited, even though there are 5 days of mucus, the mucus that the woman's seeing is not a great quantity, and that says something. We have a way of classifying the mucus cycle like this into 5 different categories. And if it's a low mucus cycle score, it means that it can be these kinds of issues. Sometimes women have total dryness. Sometimes they have short post-peak phases. Again, that can be treated. And sometimes women can have a very normal looking cycle, and potentially there is some obstruction in maybe the fallopian tube, or it's a male issue on them. But here's it is. As a teacher, when we teach people, women, how to check for the mucus, we teach the couple how it should be charted. Look what happens. Look what appears on the chart. Look what the woman's body is telling her. And it's, if you will, I think this is kind of a cry for help. I need help. But our bodies tell us that. And that's pretty amazing that by doing this, but it's because there's a standardized way of checking, standardized way of describing that we can interpret this. So to go back, the biological markers are things like how long the cycle is, the length of the pre and post-peak phases. Now the pre-peak phase can be variable from the first day of the period to the peak. That's fine. But the time after the peak to the next period should be stable. It shouldn't be 12 days for the woman and then the next cycle 4 and the next cycle 20. That means something that needs to be looked at. What about the length of the mucus cycle? How many days is it? And what about the quality of the mucus? And how long does the period last? And is there brown bleeding at the end of it? That's significant. So we can look at things. And although I'm not diagnosing a luteal phase defect, I'm very careful. I'm a nurse by profession, so I know what I can say and what I can't. Oh, and by the way, we have been at a major medical hospital since 1977, and we're still there. So we are not diagnosing problems. We are working with the doctors and referring medical issues back to doctors, and that's real important. But the chart will tell things like luteal phase deficiencies, women with endometriosis. You don't see that on a chart, but you see the structure of the cycle. There's issues with it, and then it's often a way of at least getting an idea. Maybe there's some endometriosis. It has to be visually seen, and that's done with a diagnostic laparoscopy. Polycystic ovarian disease. The people don't have the structure to the cycle. They see many changes from cycle to cycle. They see many peak days. And infertility. And I can stand in front of everybody today that I have never worked with a client with infertility where I cannot see some changes, some abnormalities on their chart. So 100% of the time, if I'm working with somebody with infertility, a couple that's been struggling a year, 5 years, 10 years, there's something to show on the chart. the doctors will do something called targeted hormonal assessment of the menstrual cycle. So when they are getting blood work, estrogen, progesterone, FSH, whatever they want, they do it not based on a day of the cycle, but based relationship to the peak day. So that is the way that the tests are always drawn. And so what's good about that is our patients are not getting blood drawn on days where you don't know what the result's going to be. In other words, if somebody wants to get a level of progesterone, then it would be drawn after the peak day, then on day 21, because day 21 could still be early in the cycle and potentially before ovulation. That's the advantage. It saves the client time, it saves money, and it's much more productive. This was passed out to everybody, and what this just shows you is the difference between nephro technology and artificial reproductive technologies. It's very small to read, but you all got these. The Creighton model has developed other methodologies. Just on this is that the life table analysis is a way of evaluating the method, not only in terms of avoiding, but also in achieving. Everybody that achieves a pregnancy, we do something called a pregnancy evaluation. We go through a series of questions with them. We do mucus cycle scoring, so we apply a quality to the mucus that they see. We also do something called a SPICE index, which means all the spiritual, physical, intellectual, creative, and emotional ways that men and women relate. Because again, we are also interested in helping couples become stronger